Welcome to all of you who are joining in at our first attempt at an AFS webinar, educational, and delighted to see all of you here. I think everyone knows John and knows that really not only has he been instrumental in creating the Foregut Society, the American Foregut Society, but also just I think due to his native inquisitiveness and also probably related to working through some of the details of understanding how LINCS works, I think John has really helped many of us rethink kind of our understanding of the GERD barrier, and that it has some complexities to it that we really hadn't considered before, or maybe as much had kind of forgotten some of what people in the surgeons in the 1950s had looked at. So without further ado, I'm going to let John take over and sort of give us an update on the GERD barrier. And there is a chat on the side there at the bottom of your Zoom screen. There's a chat button. If you have questions or thoughts during this, please feel free to do so. And send the questions to everyone. And also just leave your mute on. At the end, if we have time, we may ask you to unmute to speak. But for the time being, just leave the mute on your bottom left of your screen on so that we don't have untoward interruptions. Okay, John, take it away.
All right, thanks, Reg. So everybody, you have to forgive me for at times letting people out of the waiting room here, which will seem a little distracting, but nevertheless, thanks everybody for logging on. I guess this is our new normal nowadays with Zoom. I use Zoom more than I see people in person anymore. In fact, I Zoom with my own family. So what we're going to talk about today is really the understanding of the GERD barrier. Some of you may have heard this talk before. There are some updates to it. It almost continuously updates itself based on new publications, new manuscripts that come out. First, the most important part of any talk is the disclosures. No talk is really complete without a good set of disclosures. So first and foremost, I am a consultant for Ethicon or Thorax, which will factor in a little bit because we will talk a little bit about LINCS during this talk. The other disclosure is this is really going to be more of a story, more of story time rather than a lecture. And it's really going to be a story of my life, my understanding of the GERD barrier. So in many ways, it's sort of a comedy mixed with a tragedy of sorts. I will also disclose, for those that don't know, I am about as Demeester inbred as you can get. Now, to make matters worse, if that wasn't bad enough, I was also a math major. I have a bachelor's in science of math, which makes me a bit on the weird side to begin with. Not as bad as engineers. So if any of you know engineers, they're far worse than math majors. But when you combine all of that disclosure data, it really amounts to a bit of a bizarre talk that we'll hear in just a minute. So after admitting more people from the waiting room, we will go on. So my objectives really here tonight are really to give you a history lesson, as Reg sort of alluded to. It's going to be a history lesson that's mixed with math as well as physics. And I'm going to do it using scenes from Animal Planet. Now, I know for most of you, that's going to sound like death by PowerPoint. And I agree. It couldn't get any more boring than that when somebody starts to talk about math and physics and history all in the same lecture. It really would put anybody to sleep. But what I'd like to talk about is really the other half of the story to the GERD barrier. I think we're all pretty familiar, obviously, with the first half of the story, and that's the lower esophageal sphincter. But I think we all forget that there's more to the story than just the lower esophageal sphincter. I'm also going to talk a little bit about failure of anti-reflux procedures, because no matter what treatment we've tried, what procedure we've tried over the years, there's an unacceptably high failure rate. And I'm going to kind of shed some light onto why I think that is, which hopefully at the end of the day will allow us to decrease that failure rate. So like I said, this is really going to be more of story time and a story of my sort of bizarre, pathetic life growing up with Demeester. I was his intern, his resident, his fellow, his junior partner for 10, 15 years before he retired. And I can tell you, kind of grown up in that household for 20 plus years of my life, which I will never get back. It was all about the lower esophageal sphincter when we were talking reflux. In fact, that's really all we ever talked about was reflux. And the whole world revolved around the lower esophageal sphincter. From everything from the LES was deteriorated to these TLESRs, to LES shortening, to the abdominal length of the LES, thoracic length, pressure relationship. If you had reflux, there was some issue with your lower esophageal sphincter, period. End of story. We didn't need to discuss anything else because we discussed that the entire day. Now, during those 20 plus years, nobody mentioned a damn thing about anything else. Again, it was all about the lower esophageal sphincter. There was nothing else that was discussed at USC. And so, I'm letting more people into the waiting room, bear with me. I started to think, which is always dangerous when I start to think because it never results in anything good, but I started to think to myself, why do the majority of GERD patients have a hiatal hernia? And so I started to ask myself, well, maybe in some weird way, reflux caused the hiatal hernia to form. Or maybe the hiatal hernias were unrelated to reflux. And then I took it one step further and I started to realize that all the patients I was seeing that had recurrent reflux after whatever procedure we were talking about, they also had a hiatal hernia. And so then I did the really unthinkable, and I don't recommend doing this, but I started to read the literature. And I would argue to everybody on this call and anybody else in the world that anything we've ever wanted to know has already been answered. It's letting all these people out from the waiting room. So anyway, I'll argue that anything we've ever wanted to know is already in the literature. The study's already been done. It's already been published. The problem is nobody reads the literature, especially if it dates back more than about 6 weeks. Nobody's going to go back and read it. But like I said, everything has already been done. It's already there. And so that's why this talk is going to be a bit of a history lesson. And here is where the history lesson starts. So stay with me if you can. I think everybody thinks that the whole discussion in regards to reflux started with Rudolf Nissen, because the Nissen procedure, he must have been the one that first sort of delved into this topic. But it really started by a guy by the name of Phil Allison, who was a thoracic surgeon out of England, who asked himself the same question I asked: what is causing reflux? What is leading to this? And so Allison, this waiting room is getting painful. Allison thought that the barrier to reflux was analogous to the anorectal junction. In fact, this is one of his original drawings from his first publication in regards to reflux, showing that in his mind, the crura of the diaphragm were analogous to the puborectalis at the other end of the body. More people in the waiting room. Hold on a minute. He really didn't believe that there was much of an intrinsic sphincter, meaning he didn't think there was much of a lower esophageal sphincter. And the reason he didn't think there was a lower esophageal sphincter because there wasn't really a lot of thickening at the end of the esophagus. And when you look at it, that's true. You can't really pinpoint exactly where the lower esophageal sphincter is just by looking at the outside of the esophagus. And so he described his technique to stop reflux, and it was pretty simple. He would go in through the chest, and here's where it gets a little bit weird. He'd make a hole in the diaphragm. He'd stick his hand through the hole in the diaphragm into the abdomen, pull down the hiatal hernia, and then sew up the crura from the chest, and then close the hole in the diaphragm. That was his treatment for reflux. He thought by just fixing the hiatal hernia, the reflux would go away. He published his initial results of about 33 patients and reported that by fixing the hiatal hernia, 50% of the time, those patients' reflux was gone. Hold on, more waiting room people. It wasn't until about 5 years later that Rudolf Nissen came along and described his technique for stopping reflux. This is Nissen's original publication from 1956, where he described his treatment for reflux. And it was called the gastroplication, or Nissen later to become known as the Nissen fundoplication. And it was a series of only two patients that had reflux. They didn't have much of a hiatal hernia, but they had hiatal hernias. And his treatment for this was just to do a gastroplication, just to wrap the stomach around the end of the esophagus. His original description did not mention anything about fixing the hiatal hernias. In fact, Nissen thought that his treatment, his Nissen fundoplication, was a treatment for the hiatal hernias. In fact, that's what I was taught at USC, that you needed the bulk. You needed the bulk of that Nissen fundoplication to prevent herniation of the stomach up into the chest. If you didn't do the Nissen, the stomach would just go screaming up into the chest. And so that was one of the reasons why we had to do a Nissen fundoplication when we were fixing hiatal hernias. Hold on, more waiting room people. Now, this debate, I will say, raged on for decades between Allison and Nissen in regards to what constituted that barrier to reflux and what needed to be done to stop the reflux. Again, for Nissen, it was all about the lower esophageal sphincter. We could accomplish everything with a gastroplication. You didn't need to specifically fix the hiatal hernia. Allison, on the other hand, it was all about the hiatal hernia. That was the whole disease. If we fixed the hiatal hernia, the reflux would go away. And again, this debate raged on for decades. And I would say this debate even rages on today. And I can tell you it raged on fiercely between Tom DeMeester and myself for the 20 years that he was there. This right here is a picture of Tom DeMeester in his office when I was a resident. The picture on the right is a picture of me at breakfast this morning. But nevertheless, we had some heated arguments about what constituted the barrier and what needed to be done to stop reflux. Now, in an effort to end this debate, a guy by the name of Woodward out of Florida decided to answer this question, because in Woodward's mind, he thought, well, maybe both of them are right. Maybe both of them are right, or maybe both of them are wrong. So what he did is he decided to do both procedures. He did 127 patients where he just went in and fixed the hiatal hernia. He did nothing else, just went in there, fixed the hiatal hernia, and got out. He then did another 103 patients where he went in and just did a Nissen fundoplication. He didn't fix the hiatal hernia, he didn't put curl stitches in. Now, this was the early days of pH testing. He had all 230 patients then come back for pH testing. And what he found was that at 6 months after the procedures, 50% of the patients still had reflux, meaning if you only fixed the hernia, or if you only did a Nissen fundoplication, 50% of the people were still going to be pH positive. So it gets to this idea that there's two components to this barrier. It's not just simply the lower esophageal sphincter. It's this two sphincter hypothesis, so to speak. Hold on, more people in the waiting room. Good heavens. So one of my previous fellows, Brian Louie, published an interesting article or interesting study where he did intraoperative high resolution manometry. And he would do it at various stages of the repair so he could tease out the contribution to length and pressure that we see on manometry. And I think if you had asked me before this publication, what are those changes on manometry due to, I would have said, well, it's from me doing the Nissen fundoplication. Well, what he found was a little bit surprising, that the increased length that we see on manometry, part of it comes from me fixing the hiatal hernia, and then the other part comes from me doing the Nissen fundoplication. What was really surprising is when he looked at pressure, so the change in pressure that we see on manometry. And what he found here was that the vast majority of that increased pressure that you see on manometry after Nissen fundoplication comes from me fixing the hiatal hernia, not from doing the Nissen fundoplication. So in other words, the crura play an active role in both eating as well as reflux control. And this is something that definitely wasn't taught to me at USC. My complete understanding of the role of the crura was that it was probably involved in breathing, and it functioned as a door jamb, meaning it kept that hole open in the diaphragm so the esophagus could get through it to meet up with the stomach. Well, this is an interesting study that was done in Europe. I'm not so sure I could do it here in the US. Definitely couldn't do it at USC for obvious reasons here in a minute. But what they did was that it was a group of surgeons that got together and they were fixing ventral hernias. So patients were coming in with big incisional hernias. They were doing a laparotomy to fix those hernias. And while they had the patients open, the one surgeon said to the other surgeon, hey, wouldn't it be neat if we stuck EMG electrodes into the crura of the diaphragm? Oh, wow, yeah, that would be fascinating. Let's do it. So they did. So they went out and they got EMG electrodes. They stuck them into the crura of the diaphragm. And then the one surgeon goes, well, let's make this a little more interesting. Let's get an endoscopy. Let's do an endoscopy. Let's blow up a balloon in their esophagus while we have these EMG electrodes in there and see what happens to the crura. In other words, they wanted to simulate a food bolus in your esophagus. And lo and behold, when you have a food bolus in your esophagus, the crura of the diaphragm relax. And the reason the crura of the diaphragm relax is obvious, to allow that food bolus to make it into the stomach. Then they took it one step further. The one surgeon said to the other surgeon, wait, we can get a bigger balloon. We can get a bigger balloon and we can blow it up in the stomach. We'll blow it up in the stomach to simulate the postprandial state, and let's see what happens to the crura. Well, lo and behold, when you have a stomach full of food, the crura contract. And the reason they contract is to help to prevent postprandial reflux. So I presented all this to Tom DeMeester. I said, listen, Dr. D, you know, I think this whole GERD thing that you've been preaching for the last 20 years of your life is a little bit more than the lower esophageal sphincter. I got quite a bit of data here to suggest that there's more to the story. And he's all, well, John, that's fascinating. Fascinating. That's always what he would say. That's fascinating, John. He's humoring me at this point. He's all, but what you really need is you need to come back to me with a biomechanical model of your little theory here that the crura are playing a role in this. I said, okay, I can do that. I can do that. I was a math major, Dr. D. I was a math major. So I'm going to call my people. I'm going to call my people. I'm going to have them get together. And I'm going to have them put together a biomechanical model of what constitutes the reflux barrier. And I'm going to bring it back to you. And so I did. I called my people. I said, hey, people, I need a biomechanical model of the reflux barrier. They published it in the Journal of Biomechanical Engineering, a journal I'm sure all of you subscribe to. Fascinating article. Took me 6 weeks to get through this 3-page manuscript. But when I did, by God, I was better off for it. Because what they accomplished in this publication was exactly what DeMeester was demanding of me. They showed what the biomechanical model was for the GERD barrier. They did it using very fancy cross-sectional imaging of the hiatus and GE junction. They used something called the governing equations of finite deformation elasticity. I have no idea what that means, but it sounded super important in the manuscript. And then in addition to all that, they used a whole shitload of math equations. I mean, it was impressive. Even as a math major, I was excited about this. And you can clearly see from the top formula here that the barrier to reflux is clearly the lower esophageal sphincter and the crura of the diaphragm. It's plain as day. Now, lucky for me, being a lowly surgeon, there was also color pictures. And this made it even easier for me to understand. The green represented the crura of the diaphragm. The blue was the lower esophageal sphincter. It was plain as day that the barrier was both the LES and the crura of the diaphragm. Now this picture here, the color image, looks vaguely familiar. In fact, it looks very familiar to that diagram that Allison had drawn 50, 60 years prior, showing that the crura of the diaphragm are acting like the puba rectalis at the other end of the body. Now this was followed up by another publication by a guy by the name of Ravi Miktal. Ravi Miktal is a very well-known gastroenterologist down in the San Diego area who did a very similar study. looking at what constituted the barrier to reflux. He used high definition cross-sectional imaging and a fresh cadaver model. He used very fancy 3D computer reconstruction of that cross-sectional imaging. And what he found was very similar to the previous publication, was that that barrier was really made up of a pair of nooses. The first noose being the lower esophageal sphincter, which Ravi showed was the circular muscle of the GE junction, coming across at the angle of His to form this sling. And then in addition to that, the second noose was the crura of the diaphragm. The majority of that muscular noose being contributed by the right crus. The right crus contributes fibers over to the left. And this, in his mind, again, constituted the barrier to reflux. So I went back to Demeester. I went, listen, Dr. D, here it is. We've got 2 publications, 2 biomechanical models showing conclusively that the barrier is both the lower esophageal sphincter and the crura of the diaphragm. He said, well, John, you're getting closer. But what you really need, John, is you need a proof of concept model. And I'm like, a proof of concept model? What the hell is a proof of concept model? What does that mean? Well, you've got to take somebody that's normal, instantaneously make them abnormal, and see if they get the disease that you're saying that they'll get. So in other words, you've got to find somebody with normal crura, damage the crura, and see if they get reflux. And I'm like, Dr. D, I do that, I'm probably going to jail. That's where I'm going. That's the end of that story. He's all, well, that's what you need. And so I was up late at night, many a night, almost every night. I mean, I have no life, so it really didn't matter. But I was up really late at night thinking to myself, how am I going to prove to him that the crura are important? And so then it dawned on me. I was up late at night, 4 o'clock in the morning, it came to me. I'm like, I've got 4 cats. I've got 4 cats. What would happen if I went down in the middle of the night while the kids were asleep? They don't play with the cats anyway. They're not going to miss the cats. And I lacerated the crura of the diaphragm of my cats and see what happens. See if they got reflux. This was brilliant. I was going to be famous. People were going to know my name. I wouldn't go to jail. I'd be able to prove things to Dr. Demeester. I had this locked down. And then I started to think even more. And again, that's where it gets really dangerous. I started to think to myself, well, I already said at the beginning of this that everything I've always wanted to know has already been done. And lo and behold, it had been done. It was done by a guy by the name of Ravi Mittal, that gastroenterologist from UC San Diego. In fact, not only did he beat me to the punch by about 30 years, but you know something? Ravi had 4 cats. He had 4 cats. He went down in the middle of the night, presumably, without his kids noticing. And this is his original publication where he actually shows you how to cut the crura of your cat. So what he did is he did manometry and 24-hour pH testing on all his cats before and then after he did a crural myotomy. And lo and behold, you want to know what happens if you cut the crura of your cat? Well, lo and behold, the GE junction pressure goes down. And I didn't know this, but apparently cats have reflux. And if you cut the crura of their diaphragm, their reflux episodes go up. So again, proving that crural dysfunction leads to increased reflux. Now, Tom Demeester was never a big fan of cats. I don't know if you guys know this, but Tom Demeester was never a big fan of cats. I don't know if he was allergic to cats or what, but he hated cats. So everything in Tom Demeester's life focuses on rats. He loved the rat. And for some reason, the rat was a little different. And when I presented him with the cat study, he said, well, John, yeah, that's great, but it doesn't hold true in rats. I already did that experiment. And it pains me to say, but he's right. If you do this in a rat, it doesn't result in the same thing. And the reason it doesn't, just to be clear, is the rat is a very different animal. In fact, it's the only animal on Earth, believe it or not, that can't vomit. And the reason it can't vomit is because it has 2 very strong barriers to reflux. The crura of the diaphragm and the lower esophageal sphincter that are separated by a long distance. And so if the rat loses one of those, they still have protection from reflux, compared to the human or every other animal where those 2 areas really need to overlap. And so I told him, I said, well, many of us, most of us, not all of us in the Department of Surgery, but most of us are different than rats. And this study came out a couple of years ago, which I showed him using EndoFlip, looking at that very same concept about whether the crura of the diaphragm and the LES needed to overlap. They looked at 30 patients, and they were pretty severe reflux patients. These were 30 patients with hiatal hernias and Barrett's. They also had a control group in there, and they did EndoFlip on all these patients. And what they found, if you look at the first panel, is a normal individual, a healthy control. And here, the LES and the crura of the diaphragm overlap, and you have a very good barrier to reflux. What they found when they looked at the patients with hiatal hernias and Barrett's is that they saw a spectrum in decline, a decline in each one of the components, meaning a decline in the LES and a decline in the crura, but there was also a spectrum in the separation of the LES and crura, meaning how much of a hernia that patient had. And so what they concluded at the end of this publication was that the barrier was really a composite of those two, of the LES and the crura overlapping. And reflux, in other words, was due to the separation of those two components, as well as the individual deterioration of each one of those components. Now, to most people, this was just land-breaking, earth-shattering research. To others that have read the literature, this was really just validation of a 47-year-old study. Again, everything you ever wanted to know has already been done, and that study had already been done using conventional manometry 47, 48 years ago prior to that publication, where they looked at 112 patients, bigger study, that had hiatal hernias and reflux. They also had a control group. And again, what they found was that the barrier was a composite of both the lower esophageal sphincter and the crura. And what they saw was identical to the other publication in that there was a spectrum of deterioration of those two components and a spectrum in the degree of separation of those two components, meaning how big the hiatal hernia was. And so at the end of the day, it begs the question, or brings to the fact, I guess, that size matters. As painful as that is to say, size apparently does matter. And this was proven or published by Marco Patti a couple of years ago, where he looked at 175 patients with reflux. They were all pH positive. They underwent the normal testing that every reflux patient gets. He broke them down into groups. Either the patient didn't have a hiatal hernia, they had a small hernia, medium hernia, or a big hernia. And then he looked at the Demeester scores, esophagitis incidence, Barrett's, and hypotensive barrier to see the relationship. And what he found was this, and it should be no surprise to anybody in the audience. As the hiatal hernias got bigger, the reflux got worse. Demeester scores went up, percent of esophagitis went up, percent of patients with Barrett's went up, and the degree of hypotensive barrier went up. And so in other words, the bigger the hiatal hernia, the worse the reflux. Now, why is any of this important? Well, it's important because any anti-reflux procedure, no matter what we're talking about, then has to have two parts, because the problem has two parts. Again, the barrier to reflux is both the lower esophageal sphincter and the crura. So to stop reflux, you've got to address both of these problems. So part one of any anti-reflux procedure is going to be to fix the hiatal hernia, to restore the integrity of the crura. Again, Allison and Nissen already showed that if you only do one or the other, you're only going to be 50% good. Part two of the equation is to fix the lower esophageal sphincter. And here's where we've got a lot of options today. It's not just the Nissen anymore. We've got the Toupet, we've got the Dora, we've got the TIF, we got Lynx, we got Stretta, we got Muse. I mean, we've got a ton of ways to fix the lower esophageal sphincter. Part one of this, to fix the hernia, does kind of bring up the question again, I hate to belabor it, but does size matter? Well, I will sit here and argue, despite what Marco Patti said, is size doesn't matter. And what I mean by that is big hiatal hernias need to be fixed. Little hiatal hernias need to be fixed. And I'll even take it a step further and tell you emphatically that absent hiatal hernias need to be fixed. Now, before you think I've gone completely batshit crazy, let me explain what I mean. I will argue that the crura of the diaphragm are defective in almost all GERD patients, even if you can't identify a hiatal hernia. I will also argue that our testing is poor to assess the crura, to assess the integrity of the crura, or even identify small hiatal hernias. I will also argue that a hiatal hernia is a late sign of crural dysfunction and deterioration, meaning you just don't wake up one day with completely normal crura and a 5-centimeter hiatal hernia. The reason that hiatal hernia forms is because the crura are defective, because the crura are deteriorating. Hold on, I was letting people into the waiting room, out of the waiting room. So what this implies is, to me anyway, is that you can have crural dysfunction even if you don't have a hiatal hernia. This is an interesting publication by Peter Carrillis and John Pandolfino who looked at this very question. Can you have crural dysfunction without any evidence of a hiatal hernia? They had 31 patients with reflux. They were all pH positive. None of them had a hiatal hernia on their pre-op testing. They had 20 controls, and they did very fancy 3D high-resolution manometry so they could tease out the contribution of the lower esophageal sphincter and the crural contribution. And what they found is even in patients without any evidence of a hiatal hernia, they found that the crural contribution was significantly lower when compared to controls. They went one step further and then looked at the deterioration of each, the LES and the crura, and again found as the LES and as the crura deteriorated, acid exposure time went up. And so they concluded that the barrier to reflux was both the LES and the crura, and that the crura were defective even in patients that didn't have any evidence of a hiatal hernia. And so to me, that implies that there's a structural defect here, a structural defect in the crural muscle fibers themselves. Now, this is a fascinating study out of Italy, and again, not a study that I could do here in the US, and I don't recommend anybody in the US trying this, but just fascinating study. So it's, again, out of Italy, group of surgeons got together and decided that while we're going in there to do a hiatal hernia repair and a Nissen fundoplication, let's go ahead and take a chunk of muscle out of the crura, and we're going to have it analyzed by transmission electron microscopy to see if there's any degradation, any deterioration of the muscle fibers of the crura. So they had 33 patients with reflux. All of them had small little hiatal hernias. They were all pH positive. They excluded patients with big hernias or redos. Now, where it gets weird and where I would go to jail or couldn't do it here at USC is that they had a control group. They had a group of patients that were coming in to have their gallbladders out. That was their only complaint. Surgeons would go in there, take the gallbladder out, make a right-hand turn, go straight for the hiatus, and take a chunk of muscle out of these normal patients' crura, all in the name of science, I suppose. Well, what they found was this. If you had reflux, 94% of the time, there were muscular abnormalities of the crura. In fact, 75% of the time, these were severe abnormalities, extended disruption and degeneration of the muscle fibers themselves. The good news in all of this was that there were no abnormalities in the poor lap chole patients. Normal individuals had normal crural muscle fibers. Now, to validate my theory being that you can do anything you want in Italy, this study was repeated in 2014 with double the amount of patients. Now they had 30 controls. They recruited API patients, splenic cysts, still had a bunch of chole patients, and lo and behold, the results were the same. If you had reflux, there was over a 90% chance you were going to have structural abnormalities of the crural muscle. And so what this means is that GERD is really a connective tissue disorder. I don't think we think of it that way, but it is. GERD is a connective tissue disorder. There's been many publications that have looked at this. This is just one that has looked at the role of collagen in regards to reflux patients. So here they had 29 patients that had hiatal hernias and reflux. They used a cadaver model without hiatal hernia as their control group or comparison group and quantified or looked at the amount of collagen in the patients that had reflux. So they looked at total collagen, type 1 and type 3 collagen. And what they found was that in the GERD patients, there was across the board 60% lower amounts of collagen in the tissues around the hiatus and distal esophagus. And so all of this points us in the direction that this is really a genetic defect. GERD is a genetic defect in the production of collagen. And I won't go over the details of this study, but it's a genetic analysis study looking at a cohort of families that had clusterings of reflux in the family. And what they found was what I would have expected, that it all sort of mapped back to a collagen or to a gene that encoded for type 3 collagen. So again, GERD, I think, is more than just this mechanical issue or acid production issue that we liken it to. It's more of a genetic disorder, a connective tissue disorder in regards to collagen. So part 2 of this equation is to fix the lower esophageal sphincter. All right, we've already agreed, hopefully, many of us, some of us, 2 of us, that we have to fix the hiatal hernia, but now we also have to fix lower esophageal sphincter. Because again, getting back to the early work by Allison and Nissen, if we only fix the hernia, 50% of the patients are still going to have reflux. So again, nowadays we have a lot of options. I would say the one option we really don't have, because of the power of Google and the reputation online of the Nissen fundoplication, that one's sort of out for most patients. They associate the Nissen more with spaceflight than they do control of reflux. So it's difficult, I can tell you as a surgeon, to talk patients into having a Nissen fundoplication. So even though I'm a believer in Nissen, it's a great operation to control reflux, patients just don't want it. We do have the option, however, of partial fundoplication, and we'll get into this in a little bit more detail here in a second, but what's pictured on the screen here is an anterior partial fundoplication, or what's called a Watson fundoplication. We also have endoscopic procedures to treat reflux. We have TIF, we have Stretta, and we also have links, which we'll get into here in a little bit. Now, before we do that, I want to beat that dead horse one more time. All right, so I put up on the screen here this very fancy Netter diagram. And what it shows you is that you can spend all the time in the world fixing the battery terminals on this car. But if you don't do something to fix the other problem with the car, that dog ain't gonna hunt. That car is not gonna run. Meaning, we gotta keep in mind that you've got to fix both. You've gotta fix the hiatal hernia, and you've got to fix the lower esophageal sphincter. So accepting that, you know, and you would think I would be the last one on the planet to admit this, but the idea of doing a combined hiatal hernia and a TIF procedure makes sense. I mean, it fits the criteria of that biomechanical model. It fits the notion that we've got to fix both the hernia and the lower esophageal sphincter. If we do that, it should work. And lo and behold, it does work. This is a publication by Glenn Eide, who most of you probably know, that looked at what happens if you fix the hiatal hernia and do a TIF. Well, previous studies on TIF, when you look at their pH normalization data, normalized patients about 40% of the time, which wasn't great. I mean, patients felt better, but when you measured them, there were only about 40% that were now normal. But in those early publications on TIF, they weren't addressing the hiatal hernia. They weren't fixing the hernias. They weren't tightening up the crura. So Glenn decided to tackle this and fix the hiatal hernias and then do a TIF and see what would happen to pH normalization. Followed him up at a little less than a year, and lo and behold, when you went in there and fixed the hiatal hernia and then did a TIF, 95% of the patients were now normal from a pH standpoint. Now, the caveat here was that in those patients where the hiatus was intact, meaning they didn't have a recurrent hiatal hernia. Now, in this study, and it points out sort of the Achilles heel of anti-reflux surgery, is that 7 of the patients did indeed have a recurrent hiatal hernia, and if they did have a recurrent hiatal hernia, their pH studies were now abnormal. So again, illustrating the point that if we fix both components, reflux will be gone. The other option, I mean, we could debate whether it makes sense to do a laparoscopic hiatal hernia repair and then close them up to do a TIF, because we do have a surgical TIF. And a surgical TIF is really a Watson fundoplication. And what this is, for those that aren't familiar with it, is a 180-degree anterior wrap. So it's a little bit like an exaggerated door where it's sewn to both the crura as well as the right side of the esophagus. This is not a new procedure at all. It's been used a lot in Australia. In fact, most of the publications come out of Australia. This is just one of many that have looked at the Watson fundoplication compared to Nissen fundoplication. They looked at 5 different randomized controlled trials that looked at those 2 procedures. And what they found was that the Watson had much less dysphagia, it had much less gas and bloat, it had much less flatulence, but pH, esophagitis, and heartburn scores were similar. So they were equally effective, but the Watson had a much lower side effect profile. At the 5-year mark, they saw very similar findings that the side effect profile was much better with the Watson, and from an efficacy standpoint, the 2 were pretty similar. Lynx, even though thought of as the new kid on the block, does have over 100 publications on it. It's not all that new. It got FDA approval over 6-7 years ago now. It has a randomized controlled trial. This was published by Reg Bell, who looked at a group of patients that had predominantly regurgitative symptoms. So if you're not familiar with this study, they had 150 patients. It was a 2-to-1 randomization. All the patients were pH positive. They had small hiatal hernias, and they had a primary complaint of regurgitation. 50 patients were randomized to Lynx. 100 patients were randomized to BID PPIs. Patients were then told to come back, underwent the normal symptom questionnaires, but more importantly, underwent impedance pH testing. Primary endpoint of this study, again, if you're not familiar with it, was elimination of regurgitative symptoms. And what we saw here was that in the group that got Lynx, almost 90% of them had elimination of their regurgitative symptoms, where if you were randomized to BID PPIs, it was only about 10% of the group that had improvement in the regurgitative symptoms. GERD HRQL scores were significantly better in the patients that got Lynx, as well as 92% of the Lynx patients were able to stop their antacids altogether. What was more important to me was the pH normalization numbers. So again, all the patients came back for impedance pH testing. And what we saw here was that across the board, 91% that got Lynx had normalization of their pH parameters. Whether we were talking number of episodes or Demeester score or percent time pH less than 4, 90+% of them were now normal. Lynx even has some long-term data, which most of you are not familiar with because this has not been published. It was presented at AFS last year or earlier this year, and it is set for publication later this year by Luigi Bonavina. But what he showed was this. He looked at all the patients that were out anywhere from 6 to 12 years. These are GERD HRQL scores, and you can see compared to baseline, even at 10 years now, patients are fairly asymptomatic. He also looked at PPI utilization as well as regurgitation, dysphagia, gas and bloating. And again, across the board, patients were happy, they were off their PPIs, and their results seemed to be durable. He also looked at pH testing, and here what he saw was despite 10 years later, about 80% of them were still normalized from their pH parameters. So it begs the question, what about patients with big hernias? This hasn't been looked at with TIF or any of the others, but it has been looked at with Lynx. Again, I'll remind everybody one last time, I swear I won't beat this dead horse anymore, but again, these are 2 separate defects here. All right, we have a defect in the crura, we have a defect in the LES. They're 2 different repairs. Defect number 1 is to fix the hernia. This is really the hard part about the surgery. Fixing the LES is actually the simple part, whether we're talking Nissen, Toupet, Door, TIF, or Lynx. 90% of the repair is fixing that hiatal hernia, or at least 90% of the effort. So more math for you. That begs the question, well, what happens if I were to go in there and fix these big hernias and then do a Lynx? Well, we looked at that. We published this a number of years ago now, 4 years ago, where we looked at the first 52 patients with hernia sizes ranging up to 7 centimeters in size. Follow-up was about 12 months, and we compared this group to the group of patients we had done in the clinical trials that had these little bitty, tiny, insignificant hernias. What we found was similar to the study I showed you by Marco Patti. The bigger the hernias got, the worse the reflux got. What was surprising was when we looked at the results. And what we found was that the outcomes were actually better in the patients with the bigger hernias and the worse reflux compared to those patients with the little bitty hernias where we didn't really bother to fix them. We were seeing 90% PPI elimination rates. Symptom improvement was bigger in the patients with these big hernias that we fixed and then did a LINX. GERD HRQL scores were significantly better compared to the little hernia patients, and the incidence of mild dysphagia was about the same between the two groups. And so at the end of the day, I think the answer to the question we've been asking is that size doesn't matter. In fact, I can quote Blair Jobe on this. Blair Jobe's the one that told me, in fact, actually showed me that size didn't matter. We were at a meeting here recently and he said, I'll show you. And he showed me his publication, was just about to come out, looking at the size of the hiatal hernia across the spectrum, from no hernia to small hernia to gigantic hernia. He looked at satisfaction, GERD HRQL scores, pH normalization, and PPI elimination rates. And what he found was that it didn't matter. The efficacy was exactly the same across the spectrum of hiatal hernia size, assuming you fixed the hernia and then did a LINX. But at the end of the day, I mean, what does it really matter? Because the sort of naysayers will tell you that, well, it's really just predictable failure. I mean, it's going to fail at 10 years anyway. All anti-reflux surgery does fail at 10 years. In fact, I think there is some truth to that. This is a publication that came out a number of years ago looking at the long-term durability of Nissen fundoplication. Growing up in Demeester's household, I was told that this surgery was 95% successful. And if it was going to fail, it was going to fail in that first year. And I thought to myself after about 18 months of being faculty, wow, I must be a pretty goddamn good surgeon because I've been practiced for 18 months. I don't have a single failure. I fit right in. I'm one of the Demeester boys. Well, this study came along and they looked at the durability of Nissen fundoplication. And what they found was very similar to what Demeester said. This was a great operation in that first year or two, 95% successful. The problem was, as you got out to about 10 years, the failure rate approached 30%. This was then followed up by Sendez out of Chile, who looked at all his patients, 15 years, 10 to 15 years out after Nissen fundoplication. And what he found was very similar, about a 20% symptomatic failure rate between 10 and 15 years, and a 32% pH failure rate, meaning recurrent pH positive at that 10 to 15 year mark. And so what I was taught as a resident is, well, the reason Nissen fails is because it's disrupted. That's what Demeester would say. Well, the wrap's disrupted. We got to go in there. We got to redo the wrap. It's clearly come undone. It's reattached itself to the spleen. We got to go in there. We're going to make that better. We're going to go in there. We're going to redo the Nissen. This study came out looking at why does anti-reflux surgery fail. Like I said, what I was taught was because the wrap is disrupted. It has come undone. Well, these guys looked at that. They had 284 patients that had recurrent reflux after Nissen fundoplication. The median time to failure, again, consistent with other publications, was about 10 years before they got their reflux back. They took them to the operating room and just simply asked the question, is the crura intact? Do they have a hiatal hernia recurrence? Well, what they found was 86% of the time, the reason the patient had recurrent reflux wasn't because the wrap was disrupted. The wrap hadn't reattached itself to the spleen. The reason they had recurrent reflux was because they had a recurrent hiatal hernia. And so I will argue that the Nissen doesn't fail. What fails is the hiatal hernia repair. In fact, I'll argue that most LES repairs, if not all LES repairs, are durable. That's not what's failing. This right here is an abstract we submitted to SAGES, and it got accepted as an oral presentation. That's assuming SAGES ever happens with the COVID issues going on. But we looked at 35 patients that had recurrent reflux. Again, what I was taught was anybody with recurrent reflux, I needed to go in there, fix the hernia, undo the wrap, and redo the wrap because the wrap had clearly failed. Well, we had 35 patients that had recurrent reflux. They were all pH positive. They all had a recurrent hiatal hernia. And we decided not to fix the wrap. Our technique was to go in there, redo the hiatal hernia repair, do an endoscopy after we fixed the hernia to assess the wrap. And if the wrap looked okay, we just left it alone. Left the wrap alone, just fixed the hernia and got out. And what we found is 33 out of those 35 patients, once we fixed the hernia, the wraps looked perfect. They looked totally intact. So we did nothing except fix that hiatal hernia. And lo and behold, those 33 patients where we didn't do anything but fix the hernia, symptomatically their reflux resolved. It was gone just by fixing the recurrent hiatal hernia. So one of the main reasons I think we're seeing this high failure rate with Nissen or with any anti-reflux procedure is because we're not getting enough scarring around the hiatus of the diaphragm to prevent recurrence of the hernia. And we've looked as surgeons, we've looked at numerous things to try to improve that. The latest trend for the last 15 or 20 years has been to use some sort of biologic mesh. In fact, this paper right here by Brant Oschlager and a whole bunch of famous people, of which you will notice my name is not part of it, got together and decided to do a randomized controlled trial, looking at using biologic mesh on the hiatus after they fixed paraesophageal hernias. It was a randomized controlled trial. If you're not familiar with it, 108 patients, half of them got this magic biologic mesh. The other half just got standard hiatal hernia repair. They then asked the patients to come back at 6 months. They all got barium swallows and looked for recurrent hiatal hernias. Well, luck would have it, if you got their magic mesh, only 9% of the patients had a recurrence of their hiatal hernia. Whereas if you didn't get mesh, if you only had a standard repair, 24% of the patients had a recurrent hiatal hernia. These guys were going to be famous. They had found the holy grail of anti-reflux procedures because they had dramatically decreased that recurrent hiatal hernia rate. Now, the problem with this study, and I don't recommend doing this, but they followed their patients. They followed their patients for 5 years. And you want to know what? At 5 years, the failure rate was over 50% in both groups. Didn't matter if you sutured it closed, put mesh on it, spit on it. End of the day, 5 years later, 50% had recurrence of their hiatal hernias. Now, despite that publication, it doesn't stop us from continuing to debate and argue about using mesh at the diaphragm to fix these hiatal hernias. Some will argue that we need to use synthetic mesh, or maybe we're not mesh believers. We believe in pig mesh, human mesh, mesh panties. I don't know, something. We got to put something on the hiatus to prevent that hiatal hernia from coming back. Well, I will remind you, there are multiple randomized controlled trials. This is just one of them by David Watson, showing you that no matter what you use at the hiatus, it does not seem to be decreasing the recurrent hiatal hernia rate. And so it begs the question, how can we lower the hiatal hernia recurrence rate? And here's where it's about to get weird. I know most of you are already going, well, it's already been kind of weird to begin with. I can't imagine it going to get any weirder, but it is going to get a little weirder. So bear with me for about 3 slides here. If you follow what I talked about earlier, if this disease is partly due to a problem with collagen production, what we're doing as surgeons is we're taking really crappy tissue that's deficient in collagen, we're sewing it back together and hoping that the crappy tissue will hold. Well, if we had something to improve the collagen production of that tissue or those tissues that are healing, maybe that would decrease the hernia rate. Well, this is an interesting study done by Mark Talamini out of New York, who took in a pig model, a hiatal hernia model, where he went in, created a hiatal hernia in these pigs. He then sutured it closed, either put biologic mesh over the hiatal hernia repair, or biologic mesh coated with what's called platelet-rich plasma or filtered platelet concentrate. Platelet-rich plasma is not a new concept. It's used in orthopedics all the time, dermatology, wound healing, plastics. What it does is it tends to stimulate neovascularization, TGF, and some other things to promote wound healing. So what he did in these 6 pigs, like I said, is fix the hernias, put mesh in, or mesh mixed with platelet-rich plasma. He then sacrificed the pigs at 8 weeks and measured the pullout strength of those repairs. And what he found was that the pigs that got the platelet-rich plasma, the pullout strength was dramatically higher in the pigs that got the platelet-rich plasma. He also saw an increase in collagen deposition in that tissue around the hiatus in those pigs that got the platelet-rich plasma. Well, that's very fascinating and interesting, but it begs the question, is it going to help with Dr. Demeester's rats? Because again, being a big rat fan, we've got to find something to help his little guys. Well, this study was done looking at rats. Now, this wasn't a hiatal hernia model, it was ventral hernia model. They created a ventral hernia and again went in there and either used biologic mesh or biologic mesh coated with platelet-rich plasma. And what they found, letting somebody into the waiting room, they sacrificed these rats at 3 and 6 months. And what they found was that there was increased neovascularization in the rats that got the platelet-rich plasma. There was also a dramatically higher increased collagen deposition in these tissues that were healing in the rats that got the platelet-rich plasma. And the 6-month recurrence rate of the ventral hernias was 0 compared to 70% in the rats that only got the stratus. And so I know what you're thinking. What about my dog? My dog's got a hernia. This right here is my dog, and apparently we are one of those families that dress up our dog. But this study came out in a journal that I'm sure you all subscribe to, the Journal of Veterinary Medicine, again, looking at a dog model in regards to ventral hernias. So they took 24 dogs and again, used mesh and platelet-rich plasma, and I won't belabor the point, but again, they saw increased neovascularization in the dogs that got the platelet-rich plasma. They also saw increased gene expression of collagen 1, collagen type 3, VEGF, and TGF beta. Again, indicating that the healing with the PRP applied resulted in dramatically better tissue quality. They also noted a decreased recurrence rate. So anyway, now back to reality. Sorry, that was just a 3-slide pause into somewhere on the moon. So it begs the question, what's the recurrence rate? Well, I think we know what the recurrence rate is with Nissen. Again, it's probably in the neighborhood of 30 to 50% at the 10-year mark or 5 to 10-year mark. Lynx has recently published some data on the recurrence rate with Lynx. Now, Lynx is a little different in that it's creating its own biologic mesh by the encapsulation process, as well as it allows the patient to vent their stomachs compared to a Nissen, which is always sort of gas and bloated. This publication came out a couple of years ago from our group where we looked at those first 50 patients we had done with the bigger hernias. At USC, we asked every patient to come back for a barium swallow and an endoscopy. Follow-up in this study was about 19 months. Symptom scores were still good. Patients were off their PPIs. And our recurrence rate at 19 months was only 4%. For Nissen, that number probably would be in the neighborhood of 10 to 15% at a minimum. And so at least preliminarily, the recurrence rate with Lynx appeared lower than standard repair. We updated these numbers. This was submitted again to SAGES and accepted as an oral presentation, again, if SAGES ever occurs. Our group now extended out to 79 patients with a median follow-up now at 2.5 years. And now at 2.5 years, we're still looking at single-digit recurrence rate, somewhere in the neighborhood of 6%. Compared to, again, Nissen recurrence rates at this time probably are upwards of 20% or so. So to summarize all that babble, because I know that was a lot, I think I can leave you with this, because this clearly really to me says it all. The barrier to reflux is both the lower esophageal sphincter and the crura. And so I will remind you that the crura are defective in all GERD patients. Hiatal hernia is a late sign of this disease. Anti-reflux surgery or anti-reflux procedures are really 2 procedures in one. There has to be a crural repair and there has to be a lower esophageal sphincter repair. I'll also remind you again that I think this is a connective tissue disease. It's a genetic disease. It's more than just this mechanical problem that I think we've talked about for the last 30 years. Failure of anti-reflux surgery is failure of the cura in my mind. The Nissen is durable. The Lynx seems to be durable. The TIF, I believe, is durable. What's not durable is that hiatal hernia repair. And so the outcomes, I think, with anti-reflux procedure, despite getting a bad name over the years with Nissen fundoplication, the results are excellent. I think they're excellent. The caveat here, though, is when done by those that are experienced in hiatal hernia repair and foregut surgery. And this begs the need for specialization in foregut, hence this society. I think if we can really turn this into the specialty that it is, I think the outcomes across the board and maybe even the adoption of anti-reflux procedures will be far better. So anyway, I'm going to leave you with that, as well as a reminder that the AFS meeting has been moved to San Francisco at the end of September. Obviously, everything is dependent on COVID and those restrictions, but at a bare minimum, we will have a virtual option for the second annual meeting. We're hoping to put the majority of it on live, but if needed, we are prepared to have a component of it virtual. So anyway, at that point, I'm going to stop my babble, and I think Reg is going to come back on and share whatever questions were asked.
Yeah, John, thanks. Thanks for a great presentation and humorous and a great story as always. Question from Peter Janu. What do you recommend is the best way to determine if a patient with a greater than 6 centimeter hernia has adequate motility for a Lynx?
Yeah, I mean, I think that's a question that you know, applies really to anything. Whether we're talking Nissen or Lynx or even TIF. For somebody with the big hernias and paraesophageal hernias, we use standardized video esophagram protocol. And if they've got decent bolus transit on that barium swallow, then to us, they'll tolerate Lynx, Nissen, really anything. Manometry doesn't seem to be very reliable and many times not doable in those patients with the paraesophageal hernias. So we've gone away from doing manometry on that group.
Very good. Question from Mimi Canto. Data on Lynx is very compelling. Is there an RCT of Nissen plus hiatal hernia repair versus Lynx plus hiatal hernia repair?
Yeah, that's a great question, Mimi. You know, it's something we contemplated doing probably about 2 or 3 years.
Pardon me, if I could ask everyone to mute their mics, that will help out. So please just check lower left on your screen to make sure that that's muted.
So anyway, we contemplated doing that trial, randomized controlled trial comparing Lynx to Nissen, and we actually got it up and running at USC for a brief period of time and quickly discovered that we couldn't get anybody to agree to participate. The patients weren't dumb enough, not even in California, to be even randomized to a implant procedure that was relatively new or a surgical procedure that had a very bad reputation on the internet. We just couldn't enroll it. I know Ethicon, Thorax, and many have contemplated trying to revisit that randomized controlled trial, but it just seems to be very difficult to get patients to agree to it.
Yeah, just to add on to that, you know, not everything needs an RCT, I think, to show its benefit. I think that one of the things we are looking at least, is a retrospective analysis of a large number of patients who've had Lynx and hiatal hernia versus Nissen with hiatal hernia to see how that pans out. So it'd be nice to have an RCT on everything that we could, but not always practical. So we are trying to settle on something that we think will help answer that question for many people. And again, I think as John has said, Nissen just doesn't fly for many of you, and especially I think in the GI community, it doesn't fly. Let's see. Second question from Dimitri. Please comment on esophageal motility contribution to the barrier.
Yeah, I mean, it definitely factors into, I'm not so sure the barrier per se, but definitely the severity of the reflux, obviously. If the motility is bad, obviously they can't clear the refluxate, which obviously is going to lead to more damage to the esophagus, higher risk of Barrett's, more symptoms, all of that. How much it contributes to the actual barrier, I don't know. Again, I still think the majority of the barrier, probably 60% is the crura, and about 40% is the lower esophageal sphincter.
Great, thanks, John. And then a question, from Adriana, if a collagen genetic abnormality is an important component of GERD pathogenesis, how do we explain the really large number of patients with GERD?
Say that one more time, Reg.
So how do we explain the really large number of patients who have GERD if it's a collagen genetic abnormality? Isn't that I think the question is, isn't that a really large number of patients who have collagen defects in their diaphragm?
Well, I think yes and no. I mean, if you ask your patients closely enough, you'll find a good percentage of them, not all by any stretch, do have people in their family with reflux, and we see it all the time that it runs in reflux. Somebody in a family is obviously got to be the first person, but when you look at the tissues of the hiatus, in the vast majority of those GERD patients, they have a defect in the muscle and potentially a defect in collagen production. Is it everybody? Probably not. But is it the vast majority? I think it is. I think we need further research on it. We need bigger studies, but I'm pretty convinced that it's a connective tissue disorder.
Thanks, John. Question from Dan Lister. Do you think that axial or transverse dimension of the hiatal hernia is more important in the pre-op evaluation?
Well, I think they're equally important. I think again, as I showed in the one EndoFlip study, I mean, the LES and the forces of the crura need to overlap. And so at some point with axial disruption, you will lose any overlap. And at some degree of radial separation of the crura, you will also lose that contribution or overlap. And so I think they're equally important. And I think it illustrates how we sometimes miss the importance of the crura in these GERD patients where we don't see a hiatal hernia, let's say on barium. Their crura may be very spread apart. They haven't disrupted axially, meaning developed a big hiatal hernia, but they've lost the contribution because of the radial separation of the crura. So, like I said, I think they're both important. And again, I think it illustrates how in patients with no hiatal hernia, they still will have a decrease in the crural contribution, as Pandolfino and Carrillis showed.
Great, thanks. Let's see, a question from Ravi Nagabandi. Please comment on the role of callus gastroplasty in large hiatal hernia repairs. Are we not disrupting the LES muscle bundles with the callus procedure?
Well, I think you're preaching to the choir here. I'm not a big fan of the callus, never really have been. I don't think it's a great operation, and I don't think it's needed the vast majority of the time. I think, with extensive mediastinal dissection, you can gain length, and you do gain length on the esophagus. And so if we're short, if our esophagus seems short, we just dissect higher up in the mediastinum, and almost always we can get enough length. I mean, last time I did a callus, maybe I do a callus once every 2 or 3 years. Because I agree, I don't think it's a great operation because now you have an adynamic segment of neoesophagus that can also produce a little bit of acid. You've got risk with the staple line leaks. And in the end of the day, you're wrapping stomach around stomach when you do your repair. So anyway, I'm not a big fan. Reg, maybe you're a big fan and you can support it.
No, I'm not a big fan of it either. I think for exactly the reasons that you mentioned. And I think Ravi brings up a very good point in terms of the importance of the sling fibers in maintaining competence of the LES, and those get completely disrupted with a callus. And I think we're starting to understand that a little bit better as we start to look at the reasons that sleeve gastrectomy patients get reflux. And in some of those patients, the gastrectomy goes all the way up and really essentially divides the angle of His fibers, and I think they're very prone to reflux. So a very good point, Ravi. Thanks for that. Kareem Trad, welcome, Kareem. Good to hear you virtually. Any role for intraoperative endoflip to customize LES repair?
That is a great question. And that is one that is being actively looked at. I know Tripp Buckley in Texas is using it to try to calibrate the closure of the hiatus, as well as maybe even the repair of the lower esophageal sphincter per se. I think that's where EndoFlip may provide a lot of useful information for surgeons. We are also using EndoFlip at USC. I don't have any data to present to you yet, but I think it may help us calibrate the closure of the hiatus, because that's a question we always get asked, or I always get asked, how tight do you make the hiatal closure? Well, I make it kind of tight, but I don't have a good number to put to it, and EndoFlip may provide that. I don't know, Reg, are you using it for your closures?
We're kind of like you in the early stages of doing that. John, I think it would be worthwhile for you to comment on how you close the hiatus, because many surgeons have been taught to either use a bougie to size it, or to leave a gap between the untensioned esophagus and the hiatal repair. And I think one of the things we've learned from links is that, because we never wanted to leave a gap there for fear the links might migrate through that gap, that at least I've learned to close the hiatus precisely, I guess I would say, around an untensioned esophagus, no gap. And I've found, talking to surgeons, that many of them are a little nervous to go that route. I think it'd be worthwhile for them to hear your concepts on that.
Yeah, I think the fear for a lot of us was that if we make the crural closure tight, that we're going to have an unacceptably high incidence of dysphagia. And so I think that's why for years many people have just sort of loosely approximated it, left a nice little centimeter or so gap anteriorly around the esophagus. But you're right, Reg, because of links, we wanted it a little bit tighter. Tom DeMeester was also a fan of closing the hiatus pretty tight, and so we went to closing everything pretty tight to the point where there's really no gap around that native at-rest esophagus. And what we saw, and what we didn't see by doing that, is we saw what appeared to be a much lower recurrence rate, which some of that data I showed you, and what we didn't see was a higher dysphagia rate. And so at the end of the day, yes, we now close it much tighter than ever imagined. We don't use a bougie. We don't close it over a bougie. We haven't seen a higher dysphagia rate, and maybe we're seeing a lower recurrence rate.
Thanks, John. Thanks. I think that's a process and evolution, and one that you've kind of led the way on. Question. So from Joshua Pfeiffer, in the absence of platelet-enriched plasma, what's the best way to close the crural? Does type of suture or suture technique matter?
I think the short answer is no. The long answer is the recurrences don't occur where we put the sutures anyway. So when you go back to do a recurrent hiatal hernia, 90+% of the time it's anterior and to the patient left side. That seems to be the weak area of the diaphragm and the crural repair. So I don't think it matters what suture you use, because like you said, we're not seeing, no matter what suture we use, we're not seeing recurrences posteriorly where we close it. That's also where most surgeons, or a lot of surgeons, put their mesh, is they put it over their crural repair posteriorly. Well, again, the recurrences aren't going to occur there. They're going to occur anterior into the patient left side. That's where we need some help. Now, maybe mesh can help if we put it sort of in that kind of a reverse C fashion and cover that area where we see the recurrences. To the best of my knowledge, I haven't seen that study yet, but that may help lower the recurrence rate, or do as I think Reg does. Reg generally puts some stitches there. He closes that weak area of the anterior right portion of the hiatus, which may also help decrease that recurrence rate. Reg, maybe you can comment on how you.
Sure, John. Thanks. Yeah, I think a long time ago, we kind of observed, as you've commented, that recurrences tend to be on the left side and anteriorly. So for a while, we did a reverse C-shaped mesh to see if that would help out, and I think it probably did to some extent. The sort of I think if you look at where the recurrences are, that's where we need to think about addressing the crural repair. And so the left side or the anterior side, the left side is actually a pretty good way to take tension off of the repair and medialize the left crura, so you decrease the surface area. So we often put sutures anteriorly, not purely anteriorly, but kind of obliquely from about maybe 10 to 1 o'clock. And then on the left side from maybe 2 to 4 o'clock. So I think there are a number of different ways to, if you'll pardon going back to cats, but different ways to skin the cat. But I think we're recognizing where the problems are. Let's see. Luis Poggi asked, I think reflux is multifactorial more than only crura and LES problems. What about dysmotility or obesity?
Well, definitely. I mean, that is definitely an issue. Now, I could argue that the barrier is still the problem. The obesity is leading to increased abdominal pressure, which a normal individual barrier isn't enough. You'd have to have supranormal barrier to make up for that increased abdominal pressure. But yes, you're absolutely right. It definitely plays a role. Obesity, we've seen definitely an increase in reflux in the obese patients because of that increased abdominal pressure. Again, the motility aspects really relate more, in my mind, to that poor clearance will lead to more symptoms, more damage, higher incidence of Barrett's. It doesn't per se lead to the reflux. I think it just leads to more symptoms and reflux damage.
Okay, cool. Let's see from Alberto Gallo. If people in your practice don't want a Lynx or a Nissen, what do you offer them?
Well, we do a little bit of everything at SC. So we have recently started up a TIF program, and so one of my partners, two of my partners now do TIF. We are believers in doing this sort of the combined TIF. So if we have a patient with any size hernia, they're getting the hernia repaired, and then they're getting their TIF. We do a lot of partial fundoplications, Watsons, toupees. And we even periodically use Stretta on occasion. So we're sort of a one-stop shop. We do a little bit of everything. You, Reg?
Yeah, I think by and large, we've gone to anterior fundoplications. We're revisiting the Lynx, pardon me, the TIF hiatal hernia aspect, I think, as we get some data on that. But I think for the most part, we've done anterior partial fundoplications. It's less disruptive to anatomy than a toupee is. And it can actually be tailored in terms of how far you bring the stomach around. So that's been kind of our approach for this. And I think, basically there are some patients that if they don't want either a Lynx or a Nissen or whatever, they may not be symptomatic enough that they really need a surgery. I think that it's a quality of life issue, and by and large, it's quality of life, the severity of impact on quality of life that drives patients to surgery. So I think that's part of it too. A couple of comments from Dimitri, just chiming in that there is an incidence of hiatal, inguinal, and central hernias in patients who have hiatal hernia in a study that he published. And that he uses FLIP for hiatal hernia closure and finds it more useful than bougie. Last comment, I think that maybe, well, maybe not last comment, but another comment. That I think
wait on. Let me just comment on his observation real quick.
Yeah.
I'm old enough to remember the open Nissen era, and when I was starting my training with Demeester, we did the vast majority of our Nissens open through a laparotomy. And when we did our laparotomy, fixed the hiatal hernia, did our Nissen, and then closed the laparotomy, what we found is that the incisional hernia rate, now you could argue I was doing the closure and this is why the incisional hernia rate was so high, but the incisional hernia rate was like 40%. Whereas if you were to take a normal individual that didn't have reflux and do a laparotomy on them, their incisional hernia rate really should be around 15, 17% based on most studies. But in a GERD patient, like Dimitri's pointing out, there's some underlying connective tissue disorder. They're at higher risk for inguinal hernias, incisional hernias after a laparotomy. I think it just illustrates that point that this is a connective tissue disease. I'm off my soapbox now. You can go on.
Okay, no, that's good. Kind of like AAA repairs when they were done openly. Had that. So a comment that I think is important to address, are links, erosions, or migrations difficult to fix? What's been the safety profile with links, with erosions and migrations?
Well, that was something we were very worried about going into the clinical trials with links, would be the erosion rate. You know, I'm old enough to remember Angel Chick and obviously Lap Band, which had erosion rates of 2-3%, depending on the study. But what we found over these last 10 to 12, 13 years now is that the erosion rate with links was only about 0.3%, maybe as low as 0.15%. The better news was that it was very easy to manage. When it eroded, all we simply had to do is take the device out. 50% of the time we could take it out endoscopically, just go down there, cut one of the wires and pull the whole device out, and we didn't have to do anything else. The other half of the time we'd have to go in laparoscopically and get it out. But either way, we didn't have to do an esophagectomy, gastrectomy, or anything else. The area healed on its own. So it was very easy to deal with. In regards to migrations, we haven't seen a lot of migrations with links. Occasionally we have seen a recurrent hiatal hernia, and that's where the links is also herniated up into the mediastinum. And I can tell you, as a surgeon that does recurrent hiatal hernias after Nissen, as well as after links, the links ones tend to be easier. And the reason I think they're easier is because you can feel the links. You know where it is, and you know where, if you just stay outside of the links, you're not going to be able to damage the esophagus. Whereas with a Nissen, you don't always know exactly where the wall of the esophagus is, but with the links, I do. I don't know, Reg, you could probably comment what you think on the recurrent hernias with links versus Nissen.
Yeah, John. Yeah, just very briefly. So there have been a few reports of migration in patients who've had huge paraesophageal hernias. And so they don't have any real, I guess I'd say, retroperitoneal attachments anymore. But that's been maybe 2 or 3 case reports I've seen or heard about from that. So it may occur, but it's very infrequent. And again, if there is I'd much rather redo a herniated links than a herniated fundo. It's just much safer, I think, for a patient. A question from Mimi Canto: how are we treating obese post-lap sleeve gastrectomy patients who have terrible GERD, small hiatal hernia, no stenosis or kink in the stomach or other things to explain the reflux mechanically?
Yeah, another great question, Mimi. For us, you know, the options were limited up until recently with links. I mean, those patients would have to get a gastric bypass. But now our go-to is to go in there, fix the hiatal hernia, and put a links. We've done a couple of dozen of them now, and the results have been across the board great. I mean, I would say probably 80-85% success in getting them off PPIs and relieving their symptoms. Ethicon has just completed a prospective trial looking at that group of patients using links after sleeve gastrectomy. They're waiting for patients to come back and get symptom questionnaires and pH testing, but with COVID, I think all that's going to be a little delayed, but here soon we should have results of that prospective clinical trial.
Yeah, John, I think I just add on that, you know, the standard treatment in the past has been conversion to a Roux-Y. You know, you can go in, fix the hernia, put a links in. If that doesn't work fully, because chances are you're going to improve things, you can do a Roux-Y afterwards. Many patients who had a sleeve didn't want a Roux-Y to begin with. So I think it's a relatively low risk and reversible procedure with little downside to it. A question from Eddie: what about just fixing the hernia and not doing an anti-reflux surgery? And I don't know whether Eddie's referring to that in the setting of a paraesophageal hernia in a patient who hasn't had reflux to begin with, or just globally, because we often get that question, I think, from patients. Can't you just fix my hernia, not give me bad gas bloat with a Nissen?
Yeah, and I didn't present in this slide deck, but there's a good prospective randomized controlled trial out of Europe that looked at that very question. They had patients they were paraesophageal hernias or bigger hernias. Half of them just got hernia repair, the other half got hernia and a Nissen. And the group that only got the hernia repair, 50% of them, again, had florid reflux, LA grade B and C esophagitis, pH scores were, I think, if I remember correctly, 30 or 40 in the group. So if you only fix the hernia, there's about a 50% chance that patient's still going to have pretty severe reflux.
Yeah, it's kind of paradoxical, but when patients develop a paraesophageal hernia, the angle of His becomes more acute. And when you restore that to the abdomen, it becomes less acute and more obtuse and often changes the physiology. And that's been demonstrated years ago in some cadaver studies. So let's see, from Dr. Moran. Wasn't there at least one gastrectomy in the USC published series? I presume he's talking about LINX. Is LINX displacement an increased risk when applied to a sleeve? In other words, LINX migration, I presume.
Well, I don't think we know the answer to that, whether there's a higher risk of migration or herniation. I agree that in theory that there may be. We do put the LINX between the posterior vagus and the esophagus to try to hold it in place while it sort of scars in during the sleeve LINX surgery. But I don't think we know yet. We don't have enough data to know if the migration rate is higher in that group.
John, let me just ask you a question to follow up on that. If you have a patient, you do redos that you're putting a LINX in. If you can't, sometimes the posterior vagus has been bagged previously. What's the importance of fixation of the LINX? And if there's not a posterior vagus to use, what do you do?
Yeah, that's a good question, Reg. If the posterior vagus isn't there or we can't find it, especially on these redos, which is not uncommon, I generally won't put it between the anterior vagus. The anterior vagus tends to branch out much earlier. It's more adherent to the esophagus. I don't want to also damage it in the course of doing this. I think it is important that something has to anchor it there for those first 2 to 3 weeks while it scars in. If you don't, the natural peristaltic wave propulsion of the esophagus will push it down onto the stomach, especially in the sleeve patient. My goodness, it'll be in the mid portion of the sleeve in no time.
Yeah.
So what we do is we take a absorbable suture, Vicryl or something, put it into the muscle of the esophagus and wrap it around one of the links of the LINX device and tack it there.
Okay, good. Let's see, I'm not seeing any other questions at this point. So while we're wrapping up here, and really great discussion, great questions from many of you and actually from all of you, and very good points, John. So look forward to our next AFS webinar, May 13th. This is going to be with Peter Karillas, expert on esophageal motility. Spent his whole life really looking at that. So case presentations with Peter. And if you have case presentations that involve motility questions, feel free to email them to info@americanforegutsociety.org, and we'll choose some of those for Peter to discuss. I think that's probably it for now. If you have other questions also for John, just email them to info@americanforegutsociety.org. John, never sleeps, and you can call him at 3 a.m.
I have no life.
So he will answer your questions promptly, probably within about 2 minutes, because he never works at other things. Anyway, John, thank you very much for a fantastic presentation, and thank all of you for taking the time to join in. With that, we'll close tonight's webinar. Thanks again. Take care.
All right. Thanks, everybody. Be safe.